Good afternoon. I'm Jana Martin, Chief Executive Officer of the American Insurance Trust, known to most of you simply as the Trust. The Trust is pleased to be able to offer this informative content free of charge to our policyholders. Most of you are likely familiar with our risk management consultation service, the Advocate 800 program. It's one of our many benefits our policyholders receive through the Trust. 3 of our advocates are with us today, Doctors Joe Scropo, Daniel Taub, and Liesl Bryant. In the interest of time, we've placed their bios on a slide. Finally, this virtual webinar will earn you 1 CE credit. This can be combined with 5 other risk management credits to save up to 15% on your Trust-sponsored professional liability insurance policy. Please remember, as always, to submit your CE certificates with your policy renewal. Again, I hope everyone learns a lot over the next hour. Please join me in welcoming our esteemed presenters.
Great, thanks, Jana. And before we get going, I want to, as most of you know, if you've been watching the webinars or seen them before, it's our custom typically to begin with a set of questions, sort of prepared questions that we got either in the last webinar that we weren't able to answer or that came in the interim. And with that in mind, our intent today was to start really with questions specific to the practice of forensic assessment. And telepsych questions related to that we haven't been able to really answer directly before. But after last week's sort of question and a bunch of the, the very important social justice issues that we've been getting questions on and that are really going on in the country, we didn't feel comfortable really just ignoring that and jumping straight into the forensic pieces. So we're going to start today initially with a consideration of how, from a risk management perspective, we might really begin to think about how we can respond to some of these really important issues that are going on, both for us individually and that our clients are really bringing into our offices in one way or another. And then we'll consider that, then we'll move into a couple of the forensic questions that we've got that have been, sent in to us before. And then, of course, as always, we will take your live questions, and those can really be on a range of topics. Before we jump in, though, we do just want to acknowledge that in some ways it feels like these 2 topics don't really go together, the sort of social justice piece and the forensics. And of course, we really recognize that they have a very different emotional valence. And so we want to just acknowledge that at the outset. But we really want to address them both because they're both really important, and they're also in keeping with sort of the whole point of these webinars, which is really to address that which is happening for us right now, right, in practice, what we're seeing in our own practices. So with that, we're going to go ahead and dive right in with the first question. And Dan, I'll let you start in on this one. The question is, there's so much going on in our country right now related to police killings of Black and brown people. Are there things that we should be considering as to risk management?
Okay. Thanks, Lisa. Really important question. The brutal police killing of George Floyd illuminated again the ongoing and deep racial injustices that have pervaded our society for generations. And it comes in the context of the world everyone here knows is grappling with having shut down because of COVID and then grappling with reopening because of COVID. And we as mental health professionals are called to rise to the challenge of providing our best to our patients and clients. We're also charged with doing no harm and with doing good. And that can be particularly difficult when we are also deeply affected by our personal, societal, and political struggles. And it's my belief, and I think my colleagues in the risk management group share this belief, that this has ethical and risk management implications, right? And they're essentially threefold. The first is that it highlights the need for us as mental health professionals to engage in an intentional, elevated level of self-care. We can't support our patients and clients, our communities, if we do not take care of ourselves and one another. The second issue underscores the importance of acknowledging and focusing on the reality that there are going to be limits to our competence, particularly for many of us from dominant culture America. And we have to significantly address and develop cultural humility. Addressing racially based assumptions and beliefs is a continuing and crucial aspect of professional development, and it's a continuing and crucial aspect of reducing the likelihood of harm. The third point is that that's both ethical and risk management around oppression and around inequality, is the need for us as mental health professionals to make a strong distinction between appropriate and inappropriate advocacy. And our roles as evaluators and treating clinicians really limit our ability to engage in individual advocacy for our patients and clients, in part because these can run up against boundary violations and cause harm to patients and clients, not to mention the professionals. Those roles, however, do not and should not limit us from advocating and playing an important advocacy role in our organizations, in our communities, for social justice and also for social policy change. We have a particularly crucial role to play in advocating for the ability to critically evaluate the accumulated knowledge base, to approach what science gives us and understand scientific methodology and what the evidence is for various approaches, statements. And these are very important to address systemic inequity. Right? So at the least, Liesl, these three dimensions, self-care, cultural humility, and making a strong distinction between, but nonetheless engaging in appropriate advocacy, are aspects that we can contribute, I think, to reducing harm in our communities.
Yeah, thanks, Dan. Joe, anything you want to add there?
Yeah, I was trying to think of how this connects to forensics and the situation that's going on now. And the lesson for me, and maybe others, is that when you go into a forensic, you're just focused on the examinee, the case, and it's easy to lose sight of the greater context in which the person that I'm seeing, the forensic examinee, who could be in a jail or in a hospital, and is often a marginalized person, the context, the environment in which they're coming from, rather than just looking at this one-to-one interaction. So the lesson for me is to try to get a greater contextual understanding of the folks who I'm seeing. And part of that is knowing that what they experience is some of what we've seen in the last couple weeks.
Yeah, I think that's a great point, Joe, and Dan, all the points you mentioned. I think, just an added piece, which is general, but also related to risk management maybe, is just the idea of really listening, like really listening deeply right now to the folks who come into our offices, to the context, and to ourselves, to where we're at, to what, all of it. I think really just listening and being open to stuff is really important, because if we don't listen, we're not going to know what needs to, how to react, right? So, okay. Okay, so on that note, we'll do the sort of flip into forensics, although again, it does feel like a little bit of a jump, but we can certainly come back to this, and I assume we will if there are questions, live questions to be addressed. So the next question here in the beginning, Joe, I'll start with you on this one. And that is, are there any empirical data about the degree to which remote forensic assessments are equivalently valid as in-person assessment, and whether they would stand up to the validity challenges that are likely to be raised in an adversarial context?
Okay, so that's a good question. My sense of looking at the literature is that there's very little out there regarding the equivalence of video or remote forensic evaluations compared to face-to-face in-person evaluations. There are a few studies that look at the administration of say a test or a very limited interview by remote technology, and those appear to go reasonably well and to be reasonably equivalent. But I have found very little, if anything, that shows that a full-blown, in-depth forensic evaluation done in person is equivalent to a video evaluation. Now, that doesn't mean that it isn't, but the problem is that in an adversarial context of forensic evaluations, it's likely that you as an evaluator are going to be challenged to say, well, doctor, how do you know that the video didn't interfere or create various threats to the validity? So there are going to be challenges in doing this, but the greater context is that right now it's almost impossible to do face-to-face evaluations in certain parts of the country forensically. And so, you know, we may have to do it and just be mindful of the impact and the unknown effect that the remote technology may be having on what we're doing.
Great, thanks, Joe. Dan, any additions there?
Yeah, I mean, I want to underscore what Joe was saying. Joe, you're talking about that there's really, at best, the literature is nascent. And so what we're left with when we do remote assessments, even when we do interviews, is while there's some literature, we're going to be questioned. And if we're in an adversarial setting, the questioning is going to be much more heightened. And we have to develop reasonable arguments as to why we believe the data say what they say. So the validity and reliability issues are going to carry through from pre-administration to administration to interpretation of data, and then to the courtroom and to depositions. So yeah, I think it's a challenge. Some of us are going to have to do it, but you know, that piece of that we're still, even if we get agreements and we have everybody on board, the judge, the state prosecution and defense, they're still going to appropriately be critical of what we present.
Right, and we'll have to be ready to address those challenges.
Yeah.
Great, okay. So 2 more questions related to the forensics, which sort of unpack this a little bit. And Dan, we'll start with you on this. What are the issues that I must consider if I wish to resume or continue in-person forensic evaluations right now during the pandemic?
Sure. You know, doing in person for obvious reasons is going to result in some increased risk. Of course, the most important of which is a health risk. There may, in fact, be some limited increase in legal risk for the provider. And of course, it's not prohibited. It hasn't been. And if there's a claim, just to clarify, because we've gotten this question a lot, Liesl, as you know, and Joe, as you know, the insurance company with which the trust is affiliated will defend if somebody says that they somehow contracted COVID at your office or from you when you came into a facility. So, you know, there is insurance in place. Also, the other thing, kind of as a preface to responding to your question, Liesl, is that we're not required to go back now. We're permitted. So this is going to be a case-by-case determination for each of us. And as a team, we kind of developed about, maybe we have different numbers for it, but 5 steps to consider, okay? Please be sure to document each of these steps. The first is going to be consultation. And there may be consultation that you get for more general issues about how to go into a particular prison setting, or how you go into a local jail setting, or set up an evaluation in a personal injury case of a person who you need to travel to their home. But do get consultation. The second step is to engage in and document for each patient a deliberative process, an analysis ethically as well as from a risk management perspective of why it's appropriate to do this now in person as opposed to remote. And there are many reasonable bases for saying, I've got to do this in person, but the more pressing the forensic need or clinical need, and the more logistic barriers there are, such as the lack of reliable, valid remote tests as opposed to interviewing processes, the more one will be able to justify. The third is that it's going to be very important to develop, implement, and then provide and post safety protocols. And obviously in keeping with CDC, with state departments of health, local departments of health. But if you're going to go to a prison, for example, or jail to do a forensic assessment, evaluating what steps they're taking, but also having your own specific set of criteria. Now, some states, notably Maryland, but also New York State in particular, have some very detailed and well-articulated standards for opening offices and for doing in-person work. And I would encourage you to make sure to check with your particular state's public health department, governor's page, and look at what phase you're in, and also determine what kind of rules, if any, exist. They may just refer to CDC, or they may, like New York State, have a very, very well articulated and detailed description. The fourth point, Lisa, is it's important to have a good informed consent process, and as well as form for re-entering, if you've started doing this, say with telehealth, for re-entering in person. And it should describe risks and benefits of doing the in-person work. We generally don't recommend use of waivers of assumption of the risk, or rather waivers of liability or assumption of the risk, saying that it's the client's responsibility. But it's very important that you get them to understand that there's still a risk of contracting COVID if you see them in person in all kinds of settings, and you can't guarantee, okay? And that they understand that. And then the fifth point is an ongoing monitoring for all of us of what's the guidance that's coming out from CDC, from your local public health department, from professional organizations, and that we do our best to follow that guidance. Now, a few other points, Lisa, before I open things up to other people to comment. There are some factors to consider in this decision-making process, in these 5 steps. One is, what are the risk categories of the patient, client, or their family members, as well as the provider and their staff members? And if you're high category of risk, multiple categories your patient is, those are the kinds of situations where you're probably going to want to put off actually doing the live in person unless the situation is very pressing. What are the testing rates in your community, as well as the infection and fatality rates? And we all know how uncertain those data may be. And in some jurisdictions, they're not being tracked officially, but to the extent you can find them, they'll help you make decisions about whether the curve is flattening, whether infections are decreasing, and so on. Be aware also of your local jurisdiction phase-in process. In some counties and some states, they're much more open than other counties or jurisdictions in a particular state. So one has to be very cognizant of that. And then last, be very attentive to your own practical capacity wherever you're going, whether it's into a prison again, or it's your office to do a child custody eval. Can you engage in all of the hygiene steps and recommendations that are necessary, or that are guidelines for us, or necessary in a particular state? The things that you and I have all been seeing lots of. Can you assure hand washing, hand sanitizer, masks? Is it going to be feasible? No contact. Screens. Is there a way to have a screen in a jail setting, or to be in a different office and do it in tele or remote, but within minimizing your physical contact with the patient? Those kinds of considerations are important to keep in mind.
Oh, that was great, Dan. You got a lot of information in there very, very quickly and directly. Joe, anything you want to add? Because I know you're doing these assessments, yourself. So any additions there you want to add?
Yeah, I can speak a little bit about my own experience. I'm a forensic psychologist as well as an attorney, and I'm going back to doing forensic evaluations. So I've had to consider how to do them by video, and also how to do them face-to-face. And the face-to-face part occurs for me when I have to be giving tests to other folks. That seems to require, or tends to require, some way that I can interact directly with the person. Now, I found some ways around that. In some situations, if the person you're examining is in a facility, you may be able to get a proctor, somebody who's there at the other end, and can hand the test to the examinee as you're doing the live remote evaluation. And that person will collect them when they're done and mail them to you. And there's hopefully a secure chain of custody. And you got to observe the person taking the test remotely. So you are aware of any threats to validity that may have occurred, like somebody trying to coach the examinee, or loud noises, or lack of attention. So I figured that that is a potentially workable method. But there are some cases that I have now where there's not going to be a proctor. And I'm going to have to be in the same room with the person to administer the testing. And the two issues primarily are the physical risk to me and the examinee, which I'm addressing by masks, trying to maintain distance, using face shields even for myself and the examinee, and trying to find circulation of air in the room, because we know that the risk is greatest when we're sitting in a confined space with somebody for a long time, which is pretty much how forensic evals take place. So I've tried to address the physical safety issues, but then the problem is that some of those same protections, those PPE measures, may interfere with the validity of the testing. So when you start to think about trying to administer tests while you're wearing a mask, or you're repeating stimuli to the examinee, or the examinee is trying to speak to you, and also the mere visual shock of seeing your doctor, your evaluator, wearing a face screen and a mask, and keeping a great distance from you. All of these things have the potential to threaten the validity of the evaluation. So the challenge is to try to minimize the impact, the negative impact, or at least to account for it as much as you can, of the PPE and the other alterations in the process that you've implemented because of the need to protect yourself.
Yeah, that's really helpful, Joe. I think, one of the things that we're hearing from both of you, and I know I experienced myself, is that this is, there's a lot of complexities to this, right? And depending on what kind of forensic work you do, I know I'm in different settings. You've got to really think it through. Like, it's different when I go into a jail versus in my own office versus a hospital, depending on where the eval is, right? So it's unlike sort of just having people come to me in my office. I feel like we have to really think through a lot of different scenarios, and to underscore also what Dan said, that case by case analysis, and not only sort of the needs for the eval, but am I comfortable doing it, either because of the safety risks, or, as you point out, Joe, some of those questions about, do I think I can do a valid assessment? I think all of those are important things. So okay, the last one before we're going to move on to the live questions then, and Joe, I'll direct this to you, is what are the issues that I must consider if I wish to begin or continue remote forensic psychological evaluations, meaning evals that I do entirely via video teleconferencing? What are the things I need to think about there? Because that's, of course, different.
Yeah, it is different. My first thought is to be mindful of how the technology can interfere or alter the relationship between you and the examinee. There are some studies and articles that show that there's subtle lapses or subtle delays in video transmission, and that humans are highly sensitized to that. And that lag has an effect on us, either consciously or unconsciously. Sometimes the problem is just more obvious, that there's a poor connection, or there's gaps, or the internet goes down. So there are these, the way the technology interfaces with the relationship is an important issue in considering doing the video therapy, the video evaluation. The other is that you have much less control over the environment. you know, the person is sitting somewhere far away from you, and you're not able to as easily monitor what's going on around them, what's happening in their environment, and this also, I think, can create some impediment in being able to have a smooth engagement or to monitor the threats to the validity of the evaluation. So I think it works reasonably well if you have good internet. Both people have good internet. The person is prepared. The person is cooperative with you. There are factors that are going to make it easier in certain circumstances to do than in others. So an uncooperative examinee, someone who is in an environment that's full of distractions, that's going to be tougher. So it's important to do some triage and especially preparation before you just launch into the video evaluation.
Yeah. Dan, any additions there?
Yeah, I want to amplify just a little bit something that Joe said that I think is so important about establishing rapport. There is some research literature suggesting that the perception of viewers of videos is that the people they're interacting with are less kind and friendly. And it's difficult to estimate the kind of impact that has on us, particularly when we're interviewing somebody who might be from a different culture than we are, or where there are pre-existing and magnified power differentials as a result of race and ethnicity. And so I think there's another layer there that's very much related to what we're seeing in a global context.
Great. Thank you. Okay, so we're going to move into, sorry, I was a tiny bit distracted there with some of the, getting the live questions here in order. So we're going to move into some of those. And just to give you guys fair warning, I'm going to be jumping around in the questions there. So I'm not necessarily going to be taking them in order, but we are going to try to get to as many as we can. Although no doubt we probably, like usual, won't be able to get to all of them. But I'm going to start first with some of the questions that begin with where we began the webinar today, and that's on some of the social justice issues. And so the first question we have on that is, what are some suggestions for finding balance between being anti-racist and coming off as quote unquote judgy to clients who express racist ideas? And Dan, you wanna start with that?
You know, there's actually a growing kind of set of approaches to working with people where they're expressing racist notions overtly. In some ways, it's tougher to get at the more subtle. And when somebody comes forth with overtly racist ideas, one of the suggestions that has been put forward is that as clinicians, we lean in. We get curious. We ask them about their experience, what forms it. Essentially, it's good clinical work. And we help folks think about and challenge their ideas. But most of us know, you know, when we say to someone, you're being defensive, that works about as well as not, I mean, most of the time. And without the rapport, without the alliance that we build, our ability to challenge and have that balance between taking an anti-racist stance, but also realizing that we're working with folks and that they have these built, long built and developed systems of belief. And it does take a while to help challenge those, whether it's purely around, you know, something that we have typically diagnosed in, you know, the DSM-5, or as some have argued should be diagnosed in the DSM-5, racist ideas. And the same methods that you know as clinicians, I think, can be very powerful. But the hard part, in my view, is the countertransference that we have, and that we might react very strongly. And I take lessons from my colleagues of color around this, which is to ask questions about that response. So tell me, what makes you think that? What's been your experience? What's your belief? And so I think, Lisa, it's partly leaning in and as we most always try to do, not letting our own personal reactions take over, but keeping the focus on the person's struggle and distorted thinking and distorted experience.
Mm-hmm. Mm-hmm. Agree, Joe?
Yeah, I would, my thoughts on that are that the single best risk management principle that I'm aware of is to treat everyone with respect. That if someone is angry, disgruntled, misunderstood, feels misunderstood, that's when we're most likely to get into trouble. Now, that doesn't mean just to do nothing, but it does mean to treat everyone with respect. And I think that's also a good clinical principle. And if you can't do it, if you find that you're working with somebody who, for whatever reason, pushes your buttons too much to the point where you're losing control of your own coolness and your own ability to be respectful, that's a warning sign right there. And you need to do something about that, about continuing that treatment. It could be to refer someone elsewhere to get some consultation or something. But I would say that if you can't be respectful to everybody or a particular person, then you need to think about doing something else with that case.
Mm-hmm. No, I agree, Joe. And I think this gets back to what I was saying about listening, right? Not only to what our clients are saying, but to what our own countertransference experience may or may not be, and really taking that into account. And if we're not able to be effective for whatever reason, as you say, in keeping with the ethics code, we're going to need to address that. And consultation here, right, are one of a big risk management strategies to get consultation, with our colleagues on these issues is really important. And this is an interesting sort of spin as well. And I've received several calls on this, in the consult calls that we take, but this has a little bit to do with self-disclosure with clients, right? So the question here is, I've had patients who really want to know where I stand on these issues of racial inequality and police reform, as well as police inequities to minorities. And then some of them have radically different stances than I do, including conspiracies and thoughts. So what do you guys think sort of on that idea of how much, if a client is asking us, where do we stand? How much do we disclose about that? And how much do we not? Thoughts? Dan, you want to jump in there, and then we'll come back to you, Jim?
Of course. Well, I think in keeping with a lot of what we do, it's going to depend in part on the nature of the relationship we have with this particular patient or client, and also echoing, Joe's comment and yours, Liesl, we listen, we show respect, but I think there's some patients or clients we're going to say, yeah, this is my stance, and others we're not. And this can go in both directions. There may be clients who believe that you as a clinician are nowhere near as radical as that you should be. And I've had both callers and colleagues talk about that. And I've had others who've called saying, I have somebody who has, intense conspiracy theories and they want to know if I believe them. And I think the opacity of most approaches, not all, but most approaches to doing clinical work is a good place to start. But it's going to be an individualized judgment for us. I don't think there's going to be in any way a one-size-fits-all answer to that question, Lisa. I just don't.
Yeah, I agree. I agree completely. Joe?
Yeah, I would say that whatever you decide to do, whether you decide to disclose or not disclose or disclose some, it should be a reasoned decision on your part and thinking about why you're doing that. And hopefully the idea is that what you're doing is in furtherance of the therapy. So I think one part is to consider your own comfort level, but ultimately whatever you decide, I think should be based on what you think is going to advance the treatment of this particular person. And that should ultimately drive what you decide to do.
Yeah, I think that's an excellent point. Okay, here's another question. It's a little bit long, so bear with me. As a white psychotherapist, I sometimes feel quite uncomfortable when therapy clients express views about groups of people that I feel are intolerant, dehumanizing, ignorant, or so on. These clients are not typically seeking to change those views, and I believe my discomfort comes from the dissonance I feel between my efforts to join the client where they are, etc., and the hurt and anger and guilt that I feel hearing their views and not challenging those views. I think my discomfort is telling me I should do something different, but I've been trained not to impose my values on my clients. What do you suggest I do differently? Do you want to start, Dan?
Sure. I mean, in some ways, it's an echo of what each of us has been saying, but I think this is where what people come in for. We often see, for example, somebody who comes in to services and says, I feel very anxious, but then we end up, in our own minds or diagnosing them with a major depressive disorder, right? So we may not have the same approach that our client does. But I think this goes to the idea of trying to balance that respect and that sense of, even if one disagrees vehemently with the views of the person one is working with, a sense of respect, but also the listening that you were talking about, Liesl, with drawing out and leaning in and finding out more. And that will allow, I believe, for some challenge of the ideas. But the treatment's driven by the client's needs, right? And with each client who comes in, each patient who comes in, we're making a decision about what we think the appropriate direction will be. In terms of one's own guilt, I think the idea for us is to reflect on, as you're doing, the person who asked the question, to reflect on, so does this mean I must say something or I shouldn't say something? And this is where consultation about particular cases becomes very important. In one case or one person I'm working with, I may find that it's most appropriate for me to say, you're talking about whoever the disparaged group might be, and I'm wondering what happened to you, right? And another person, I might be a lot more disclosing, right? I might say something about my discomfort, depending on the nature of the relationship. So again, I don't think there's a one size fits all when it comes to how we approach a particular patient, but how we approach our responses. I think that is, we do some reflection, some digging, we get consultation, and we try to find something that's in the service of the therapy we're doing, or the whatever kind of service we're providing, as Joe pointed out, well reasoned, but that also reflects who we are. There are going to be some patients where we are not going to be effective. There are going to be people who we find either their beliefs or their interactions with us being such that we can't proceed. And so then we also can get consultation about how do we terminate appropriately and transfer care.
Mm-hmm. And I'm gonna, Joe, did you want to add something? Because I also have a question that ties this in with
Yeah, I would say what helps me when I hear patients who are saying things that I find offensive or difficult to tolerate is to remember that they're here because something has brought them here to change, presumably. They want to change, someone else wants them to change, but there's some effort to change or desire to change. So that's hopeful to me, even if what I'm hearing is hard to digest. And the second is that I believe that we're all afraid of the stranger, afraid of the thing or the person that we don't know or don't understand. So when I look at it in that way, it becomes easier to hear things as coming from perhaps ignorance or lack of familiarity or bad experience or something, but that it's an inherent human tendency to be afraid of what we don't understand or don't know. And that helps me to accept the person more.
Mm. I really appreciate, Joe, that it reminds me a little, I think it was Maya Angelou, I don't remember the exact quote, but she talks about how, any experience that we have or see or experience is a human experience, right? That all experiences are human, good, bad, anywhere in between. And I think, that means if we're human, we also are capable of all experiences. And so just being open to that, and the compassion and the humility and the, openness and curiosity, I think is important in a non-judgmental way. So I really appreciate that, Joe. So here's a question that links it sort of more specifically with, and this does overlap a little bit with what we've talked about, more specifically with forensics. I'm a forensic psychologist in Minneapolis, conducting court-ordered evaluations of defendants referred for various types of evals, competence to stand trial, risk assessment, etc. Many examinees are Black, many examiners are white. In the wake of George Floyd's death in police custody, some examinees have been asking examiners at the outset of the evaluation what they think about the protests and other events surrounding the killing. How might examiners respond in a way that conveys empathy while also importantly maintaining objectivity and focus on the forensic task?
That's a very challenging question and a challenging scenario. I think what makes it particularly difficult for a forensic evaluator is that it's not really our job to establish an empathic relationship or a typical clinical relationship with our examinee. There's a level of skepticism, and the nature of the work is often kind of somewhat oppositional, or the interests diverge between the examinee and you, the evaluator. So I think that I'd be careful about going too far in the direction of trying to be sympathetic when it may not really fit your role. Again, I would just come down to respect, that I would be open to whatever the person has to say, and I would try to listen, and if I get clues that they're reacting to me in some particular way, I would try to explore it. But I do think you have to maintain the bound.
Oops.
Looks like we lost Joe. Dan, do you want to jump in there? Maybe he'll come.
What I'm imagining he'll say, or is going to start up any moment, is maintaining that balance.
Forensic evaluators.
There we go.
Because otherwise you're making.
Yeah.
We lost you for just a minute there, Joe.
Yeah.
Oh, I'm sorry. Oh, okay. I'm sorry.
Yeah, we lost you when you said maintaining that.
I was just going to say it's more challenging for forensics evaluators because of the need to maintain that somewhat of a distant stance. It's almost out of fairness to the person too, because you don't want to try to seduce them into saying things that are going to be contrary to their interest. So ultimately, it just, to me, comes down to being respectful and listening.
Yeah.
Dan, any additions before we move on?
No, why don't you go ahead, Lisa?
So another question here. I've noticed many colleagues being very open about their opinions on social media, specifically about racism. What thoughts do you have about the risks involved with supporting particular movements or organizations and or voicing opinion in the public arena when you're a therapist? And maybe I'll let you start with this because it gets back to that question you mentioned earlier about advocacy and how do we do that in English?
Well, the first thing to remember is that while we do have professional roles, we also, I believe, may still have the First Amendment, which says that psychologists, as well as every other professional, has a right in their own personal lives to express their opinions and to be actively engaged politically. That doesn't mean that those kind of actions may not reverberate in our consultation rooms, our evaluation rooms. Somebody who sees a video of, if you're a clinician who's out on the street who's protesting. On the other hand, whatever it is that one does. So like many of our boundary challenges now in the digital world, I think it's going to be important for the clinician to, while there are risks to impacting treatment, the important issue is you invite it in and you ask people if they've, have they seen anything, and if they see things online or publicly and it happens to involve you, you really encourage them to come in and talk about it. And this is where it can also get challenging, because part of what happens is somebody may challenge your political views in the session. And that balance between listening and respect and empathy is also something that it could get ruptured. But I would be very remiss if I were to say, well, you have to limit your advocacy in whatever directions you believe your advocacy should go, because you're also a therapist. And I know that traditionally that's been one of the things that has been advised, or the idea that we have to be very careful. But I also think there are times where all professionals must speak out, and speaking out on behalf of what you believe is important, and it's going to have an impact. And the degree of that impact on the professional life, we have to monitor, and then again, we try to deal with it appropriately. And if we can't, if we get stuck or at an impasse with a patient or client, then we think about how to appropriately refer to support the welfare of the person we're working with.
Mm-hmm. Joe, anything to add?
Yeah, I mean, I would say that, I mean, it's a fundamental right and responsibility as a human being to express your views, and if you're so inclined to try to change things, and that's fine. I think where it's important to be careful is the inadvertent leakage from your social media, or the inadvertent leakage from your online life, things that are not controlled well by you. So to the extent that you don't need to have that stuff out there, I think it's probably better that you're not. But that's different than going out consciously and purposely making a statement and doing and saying what you feel you need to do. So I would distinguish between those two situations. I don't think you need to make it too easy for folks to get into your personal life. And a lot of us do that inadvertently just because we don't know how to keep good boundaries with our online persona. So those are two different things, and I'd approach them differently.
Yeah, I think that's a really important distinction because, it also, on the one hand, like you say, Dan, we don't want to stop, it's not true that we can't advocate or that, because not saying anything, not speaking up also has an impact, right? And so we're trying to find that balance again. But Joe, I completely agree with you. The last thing we want to do is start having a dialogue with our clients on social media about these things, right? In terms of those boundaries. So I think both of those are very good points. Okay, I'm noticing the time, and I want to try to get us to some of these other questions as well. So I guess, and Joe, I will start with you on this one. Identifying risk management considerations in conducting in-person testing in a patient's home to reduce their external exposures. And I know that's a little bit, I've also seen this taken up in terms of child custody evaluators who are going into the homes to do the child, the home visit part. But I'd be interested in both of your thoughts on, is that safe to do? What are the considerations we need to be taking into account? Those kinds of things.
Well, I mean, it's not safe, or at least there's no way to know if it's safe if you're going into an environment that you don't have control over and don't know what's going on. It would be safest to assume that their infection is there, and to adopt universal precautions, to assume that you must protect yourself and others. I think the less control you have over the environment, the tougher it's going to be. If you absolutely feel like you have to go into someone's home, I'm not sure what the difference is between doing that and going to your office. I would prefer the office. I think you have a little more control. And when you're in someone's home, there's a tendency for the examinee or the patient to feel a weakening of the boundary, that you're in a social relationship because you're in their home, you're a guest. And that tends to play itself out in some ways, unless you're very careful to maintain the professional boundary. So if you have to do it, be very careful and be mindful of how that can affect how the client is experiencing you differently now that you're in their home.
Well, I think, Lisa, that it is riskier to go to people's homes for the reason that Joe is naming, which is that it's less controlled. And if you have to, I would be sure to think through carefully what your personal protective equipment is going to be, and also to have a clear policy and to communicate it before you go in about all kinds of aspects around contagion at this point. Because the boundary issues are, of course, going to be heightened with the reality of COVID, and what Joe was pointing to about the kind of less formality and the sense of it being a social contact. I think the structuring of that interaction becomes critical. In doing custody evaluations, visit both homes, and I'd go to, if there were two homes, and I'd go to the kids' bedrooms. Well, there now is going to be an issue of, well, I'm going to be wearing a mask if I go in, maybe a face shield as well. That the likelihood of the family complying with my requests are lower because they're in their physical environment. So I have to say to them, if I'm going to be meeting with you in your home, here's what I'll need to do and here's what I want you to do. And then I would put it in writing. These are just examples, Liesl, of the kinds of steps that I think we need to take. And thinking through possible scenarios and the experiences we've had in prior homes when we've done, in-home assessments, whether custody or for child protective purposes, and what's come up, we have to anticipate and then try to plan for those around the issue of contagion to us and to family, as well as some of the implications regarding reliability and validity of the information we're getting.
I agree. Okay, a couple more questions I'm going to try to squeeze in here. One, all of it, so I think this is referring to the forensic stuff that we talked about earlier. All of this sounds super helpful, but is not always practical, with some judges who are pressing forward with hearings and demanding evals despite COVID and requests by me for accommodations. This is a particular problem with neuropsych evals. Do defense attorneys have a basis for appeal? So do you want to start with that?
Yeah, I mean, first of all, I wouldn't allow myself to be pressured to the extent that I can assert my own desire or will here. So I would advocate strongly if I really felt that I'm being asked to do something that is either unsafe or is going to result in an invalid evaluation. And I would mount the argument with the attorney who retained me or the attorneys on the case and the judge. And I would try to educate the judge I'm not sure that the judges or attorneys really understand the extent of the risk that's involved and the validity threats. So I would try to take an educational approach before I got into a confrontation. And my sense is that there's a likelihood that there'll be some understanding, and I'll try to find a compromise that will satisfy me and hopefully satisfy the attorneys in the court as well.
When it doesn't happen, which it can, it's possible. I just had a situation the past 2 weeks where a judge is insisting on an in-person deposition. Okay, judge is not hearing the arguments. I think that what Joe's talking about is we say that I'm not the person for you. I'm not the person if I'm not being compelled, right, as an expert. I'm not the person to be able to complete this evaluation. Problem arises when we've been court ordered or when we've gone through the process already. And now we're giving testimony as to our evaluation and we're saying we want it to be remote and the judge and the parties are saying no. Maybe there would be a basis for an appeal. The problem is that as an expert, we don't have standing. That's the party. And so it would have to be retaining counsel who's willing to take it, and they may or may not. It also may be something, if it's egregious enough, that one might want to bring to state organizations and see if they might advocate and assist in appeals, if that happens. But I think ultimately, Liesl, it's not going to happen very often. I've heard it once. Most of the time when I'm hearing in my community and around the country, and I think you two are, is that everything's delayed. So in those rare instances where it's not, I think we withdraw if we can, and if we can't, we may use external sources to help us advocate.
Yeah, and I think a key, like both of you are saying, is that piece about educating, right? Explaining why. Okay, another question. What steps would you recommend to university counseling center psychologists who do not feel it is safe to return to in-person work, yet university administration expects that they will do so? So this gets at the piece between we feel one way and in essence our boss is telling us to do something else.
Yeah.
Dan, do you want to take a first dive at that, and then Joe?
Sure. In some ways, it's very similar to what we've been talking about, in the forensic realm. I think education and also talking to administration about the risks, and particularly talking to administration about the risks to the university. If there's harm to their employee, the cases where people have been able to be successful where folks have been exposed to, for example, to Ebola, or when the institution simply ignored the steps that needed to be taken in order to protect employees. So one of the things that can happen is laying out, here's what's going to be required in order for the university to do this, and we really think it's risky. If it comes push to shove and your boss is saying you have to do this, and they're not listening, then, I mean, if you've got a union, this is the time to go to it. Okay. If you don't, which often happens in university settings, even for professors, because unless you're in a public university, professors are generally not allowed to unionize, with exceptions. Then, really it comes down to what level of risk do you think you are experiencing by going into the counseling center, and then having many of the safety protocols that we've been talking about to try to reduce the likelihood of there being some harm, but continually putting pressure on administration. I think that's going to be important.
And I would just add to that there are regulations, federal and state, that control the workplace environment, and they're emerging now as COVID continues and as we return to reopening. So I would look to that guidance. I would look to OSHA. I would look to my state guidance as an employee about what protections I have. And I suspect that there are quite substantial protections for you.
Great. And one last question we're going to squeeze in. We got 2 minutes, so I'll ask both of you to be super brief, but this is one that keeps coming up both in our webinars and then also on calls. It says, I am planning to give up my office and work from home permanently, I think is what he means here. What are some of the considerations? For example, will some insurance not pay for teletherapy? Will my home address be revealed? Do I need an address for mail? Can you give us like a 2 or 3 sentence comment there? Joe, why don't we start with you?
My short answer is yeah, all those things are possible. So you need to figure in the risk of that into what you're doing. You can more advocate for yourself and try to limit those intrusions from third parties, but it may be a challenge.
Yeah, and just to take the insurance part of it, right now, of course, there are efforts underway in many states and also nationally to extend various kinds of insurance waivers as regards to where we provide services from. But there are some private insurance companies that have traditionally not paid when the professional is a home office. And they'll say, we will not reimburse you. So you have to take that into consideration. It's not wise to be dishonest about that. If you're going to be from home, you may have to consider not working with that insurance company.
Right. And this is just so those are both excellent points. Just to sum that up, I think this is a really good example of when consulting is really important, right? Because there are a lot of things to think about. We can't, in the 30 seconds we have left. But definitely if you're a trust insured, give us a call. We're happy to chat about that.